More recently, actually, I think last week, with Dr. Dinkin and I published a paper that incorporates all the experience, all the publications in relating to venous stenting and IIH until like a few months ago. And this included either relatively large case reports or retrospective or prospective studies. There was like a little more than 1,600 patients in the literature, and we analyzed the results in terms of effectiveness in symptoms, papilledema, and I will go through this quickly. But this is like a typical for our patients on the call. This is a typical presentation of a patient with severe papilledema. This is the appearance of the abnormally swollen optic discs on ophthalmological exam. This is the thickening of the optic nerve on the test called OCT, what is called the RNFL, retinal nerve layer thickness. And this patient on the top row was at presentation. On the second row, there is no significant change. This is after maximal medical management. At the same time, the vision loss is worse, -15 compared to almost -5 a few weeks before, and -5.5 compared to -4 a few weeks before. So no improvement in papilledema or optic nerve swelling, but worsening of visual loss during maximal medical management. And then after stenting, we have normalization of the papilledema and the optic nerve disc. No, essentially normal appearance on OCT, and significant improvement of visual field loss. This is like a typical story of a patient that we would treat with severe papilledema and vision loss. These are all the studies that mentioned effect on opening pressure before and after stenting. So the total is 800 patients, and the numbers here are the average pressure recorded in each study before treatment, and in blue, and after treatment in orange. And you see some papers are like 1 patient, 10 patients, 20 something. I think this is the paper I mentioned earlier with 50 patients from our group. But on average, we have a significant improvement of pressure from 33 to less than 20 before and after stenting. Again, these are heterogeneous studies grouped together, but there is some value in these results when you see them in large numbers. Then we looked at symptoms, improvement or resolution or unchanged symptoms. And we see, for example, starting with headache, that there was like reported outcomes in 1,100 patients, again, multiple different heterogeneous studies. And there was improvement or resolution of headaches in about 80% of patients, and no improvement or worsening in 22% of patients. So that is a significant number of patients that still suffer from headaches after stenting, and we need to focus a little more on this with our neurology colleagues, how to improve their quality of life. In terms of pulsatile tinnitus, I'm a little surprised to see that across the board, there is almost 18% almost 20% of patients with unchanged pulsatile tinnitus after stenting. This is certainly not the experience I have and I published, but this is what the data show across different studies. And then in terms of visual symptoms, the majority of patients have visual symptoms, means blurry vision, or any impairment of vision. That can include floaters, for example. So it's a little bit of very broad term, but we try to lump as much studies together as possible. But again, the majority of patients they have significant improvement of visual symptoms. Diplopia universally resolves, and transient visual obscurations in 80% of patients were recorded as being resolved. So this is a good overview, I think, of how improve IIH symptoms after stenting. And again, the problem we have is with persistent headaches. Papilledema was resolved or improved in 85% of patients or 84% of patients. So major numbers, major outcomes in terms of papilledema. And this is the RNFL before and after treatment that goes along with the improvement of papilledema. Again, significant change in the optic nerve thickness after stenting. That again goes along with the improvement in vision and papilledema. In terms of vision loss, again, based on the papers that reported visual outcomes, there is significant change from -7.3 to -4.7. So significant improvement in vision loss in almost every paper or every study that included this variable in their outcomes.
I have two questions from the audience, Athos. One is from a neuroradiologist who has a patient with IIH, papilledema, partially improving on Diamox, still headaches, and the MRV is showing transverse sinus hypoplasia. And this neuroradiologist is wondering, how do you differentiate stenosis, where you may stent, versus sinus hypoplasia?
Well, there is no, there's no fixed criterion. You have to, obviously, if one side is hypoplastic, the other transverse sinus has to be significantly larger, or then there has to be an occipital sinus or two occipital sinuses. I mean, this is something that is not very common, but it exists, that the majority of drainage is via occipital sinuses. And these are amenable to stenting also. I think it's a little more complex to do occipital sinus stenting rather than transverse and sigmoid sinus, but it's certainly feasible. So in terms of hypoplastic versus not, I think you have to judge based on the contralateral side. It's a little bit of a, how can I say this? It's a relative decision, but if both sides are hypoplastic, then there has to be something else, like occipital sinuses. If there is stenosis, if one side is hypoplastic, and the source then you expect to have significant venous stenosis on the dominant venous sinus on the contralateral side. So without seeing the MRV itself, it's difficult to say more, but I'm happy to. I'm reachable by email or phone if I'm happy to review this scans.
I have another question. A patient who doesn't have typical IIH, but in this example, an empty cellar, tinnitus and headaches, is there benefit in stenting stenosis of a transverse sinus?
I mean, I was going to talk a little bit about this later, but I think it's a good introduction to the next part. And the answer is this is primarily driven by symptoms. If there is debilitating pulsatile tinnitus that correlates with the venous stenosis, then the indication to treat is that if the patient suffers from pulsatile tinnitus. The empty cella itself is, it's an imaging finding that over time we realize that it's less and less associated with high pressure and more associated with venous stenosis. There's some association with the lymphatic drainage. I think it's a little elusive as to truly what this means. Personally, I don't give much significance to empty-sella, other than it makes me think of the possibility of the patient having venous sinus stenosis if I see this on an MRI scan. And again, it has to be in the appropriate clinical context. But yes, treatment for pulsatile tinnitus with venous stenosis is the study that we did a few years ago that I mentioned earlier, and it's something that we practice a lot in the appropriate patient. No question.